Welcome to the deep dive. Today we're really plunging into a stack of sources, fresh research, professional guides, policy updates, all pointing to a field that's changing fast.
Yeah, infectious diseases pharmacy. It's impacting healthcare right now.
Absolutely. We're looking at developments mostly from 2024, 2025, giving you a look at, well, the cutting edge.
Exactly.
Our mission with this deep dive, to cut through the noise, really extract the most important insights for you, and give you a shortcut to being genuinely well-informed on this crucial topic.
Think of us as guides, maybe finding the surprising facts, the key takeaways for you.
Like the highlights reel and the so what from a mountain of information.
Pretty much.
Exactly. So let's unpack this. We're diving deep into how infectious diseases pharmacists are not just adapting, but actually shaping the future of fighting infections and resistance.
Right. So let's maybe start by setting the stage a bit. What the sources consistently show is that infectious diseases, or ID pharmacy, is just incredibly dynamic.
It has to be, right?
It really does. It's constantly responding to brand new pathogens, evolving resistance patterns, rapid treatment advances. It's anything but static.
That it feels like the COVID-19 pandemic really kind of catapulted their role into the spotlight. The sources seem to emphasize that moment.
Oh, definitely. It underscored the absolutely vital contributions pharmacists made, showed they could pivot, step up in ways we hadn't maybe seen before.
And crucially, the sources suggest that shift wasn't just temporary, like for the emergency.
Exactly. Healthcare systems are now integrating those expanded roles. The expectation isn't just to, snap back to pre-pandemic norms. It's changed things.
That's a big shift. So does that mean understanding ID treatments is now essential for, well, pretty much all pharmacists, not just the specialists?
That's a key takeaway, yes. I mean, the ID pharmacy specialty itself, it grew out of a need for expert consultation on really complex antimicrobial cases.
Which is still needed, I imagine.
Oh, more than ever. That need is only accelerating because treatments are getting so complex. But yes, the foundational understanding of ID pharmacotherapy is becoming relevant for a much wider range of practitioners now.
Okay, so if everyone needs that baseline knowledge, the specialists become even more critical, almost like force multipliers.
Precisely. They become the crucial educators, the mentors, the high-level consultants supporting generalist pharmacists, amplifying their impact across the whole system. And this evolution really highlights why ID pharmacists need not just deep clinical knowledge, but also strong communication, strong leadership skills too.
Fascinating. Okay, let's talk antimicrobial stewardship, AMS. It's like a core battleground against resistance, right?
Yeah.
And ID pharmacists are leaders here. What innovations are popping up in these 2024, 2025 sources?
Yeah, what's really clear is how pharmacist-led AMS programs consistently show significant positive impacts. We're talking better patient outcomes, smarter resource use, and, a direct hit against resistance spread.
And some clever innovations, too.
Definitely. For instance, traditional AMS consultations, ASPCs, they've shown they reduce patient length of stay, which is great.
Right.
But one study in the sources focused on pediatrics. It went further. They actually developed a risk prediction model
Okay.
to help identify kids who might be at higher risk for a prolonged stay, even if they're getting an ASPC.
Yeah.
This lets pharmacists proactively target even more intensive help where it's most needed.
That's smart. Using data to fine-tune the focus. What about extending stewardship, like beyond the usual daytime hours or physical location?
That's where technology is really a game changer. The sources highlight a really impressive example, an inpatient pharmacist-led tele-antimicrobial stewardship program, a tele-ASP.
Tele-ASX. How did that work out?
Amazingly well, actually. This program saw a huge 237% increase in interventions, specifically during off hours, evenings, nights.
Wow, over 200% just by being available remotely. That's massive.
It is. And the quality was their two recommendations from this tele-ASP had a remarkably high acceptance rate, 96.8%.
Okay.
And it delivered serious economic value, a 74.1% increase in documented cost savings and avoidance. That went from around $5.9 million up to over $10.3 million. Plus, it cut the average patient length of stay by 1.1 days.
So tele-ASP isn't just about covering more ground, it's proving real measurable value, expanding vital services to times and places that might otherwise lack them.
Exactly. And this trend, this expansion of pharmacist-led AMS, it's not just local. A big 20-year global review published in 2025 tracked a steady increase in these studies worldwide.
What were the common approaches?
Audit and feedback was very common. But recent data, especially from high-income countries between 2016 and 2020, shows pharmacists getting much more involved in outpatient AMS and even leading things like beta-lactam or penicillin allergy assessments.
It really does sound like a global push.
It is. Another example comes from an Indian tertiary care hospital. They showed combining clinician education with pharmacist-led audit, and feedback was super effective. High acceptance rate, nearly 80%.
And it reduced use of critical drugs.
Significantly. Things like polymyxins, carbapenems, glycopeptides, really important reductions.
So for you, the listener, this isn't just academic stuff. These innovations are happening everywhere, directly impacting how infections get treated in hospitals, potentially shorter stays, better outcomes. It's a worldwide movement.
Now, shifting gears a bit, the sources also dive into the intersection of artificial intelligence, AI, and AMS, which is evolving fast.
AI and antimicrobial stewardship, that feels pretty futuristic, doesn't it? How's it being used?
Well, a recent systematic review, updated right through October 2024, looked into this. It found that machine learning, ML, when it's built into clinical decision support systems, it showed promise.
How so?
It could help improve predicting antimicrobial resistance, maybe suggest ways to optimize drug use, so AI can definitely enhance the data analysis side.
Okay, promising for crunching numbers.
Yeah.
But is AI ready to make complex clinical calls or, replace the pharmacist?
That's where the review and other sources sound a really critical note of caution. The same review found that large language models, LLMs, think tools like ChatGPT, they actually showed higher rates of prescribing errors.
Higher errors? Really?
Yes, and potential patient safety risks when used to guide antimicrobial therapy. They often needed very specific, expert-level prompts just to function correctly.
So the fancy conversational tools weren't as reliable as the models trained on specific clinical data.
Exactly. And this was backed up by a finding highlighted at ESCM&D Global 2024, a study concluding ChatGPT was less effective than experienced clinical pharmacists in guiding infection management decisions.
So the big takeaway is AI is a powerful assistant, maybe, but not a substitute for that expert human judgment.
Precisely. The sources strongly emphasize that AI right now is best used to augment and support human expertise, especially that nuanced, patient-specific clinical reasoning ID pharmacists provide.
Right.
ML can handle the complex data patterns, maybe freeing up the pharmacist to focus on the critical thinking, the complex reasoning.
It sounds like this fundamentally shifts AMS then, makes it more proactive, predictive, leveraging tech and huge data sets.
It absolutely does. Pharmacists are becoming, in a way, architects and managers of these complex stewardship systems, integrating data, like the NHSN AUR data, that's the National Healthcare Safety Network's antimicrobial use and resistance data.
Which is mentioned in the IDSAP curriculum.
Right, IDSA 2025 covers it. This requires pharmacists to build new skills: data analytics, technology evaluation, implementation, systems thinking.
Okay, so AMS is getting smarter, more high-tech. But the sources suggest ID pharmacists are doing a lot more than just traditional stewardship now, yeah. Their scope is broadening out.
Oh, significantly. And ID pharmacist's expertise extends well beyond just the standard AMS rounds. The idea of the ID consultant pharmacist is key here.
A distinct role.
Yeah, it emerged specifically because of the need for deep expertise in managing the most complex antimicrobial cases. And with modern treatments getting more complicated, that need is just accelerating.
How do we know these consultants are really having an impact? Is there, hard data?
There's some compelling quantitative data from a study looking at ID pharmacist curbsides, basically informal consult.
Curbsides, like quick questions in the hallway.
Kind of, yeah. ID docs and providers asking ID-trained pharmacists questions on the fly. Over just 3 months, they tracked 782 of these questions. And here's the kicker: a remarkable 89.8%.
Almost 90%.
Exactly. 89.8% of those interactions resulted in a clinical change in patient management based directly on the pharmacist's advice.
Just think about that. Almost 9 out of 10 times, a quick question led to a direct change in care. That's huge value right there within the clinical team.
It really quantifies their influence. The most frequent questions were about tough areas: gram-negative resistance, antifungal therapy, antimicrobial allergy.
And the changes were significant.
Concrete changes. A new antimicrobial dose recommended in over half the cases. Or even switching to a completely different drug in about half the interactions.
That statistic alone speaks volumes. Wow. What about taking this expertise outside the hospital walls?
Right, that's where outpatient parenteral antimicrobial therapy, OPT, comes in. It's a major growth area. ASHP's IDSEP Book 2 from late 2024 has a whole module on it.
What does that cover?
Things like the CDC's core elements for OKate programs, the tricky decision-making between IV and oral therapy when someone's going home, that kind of stuff.
And do we know what kind of workforce is needed for OPA?
Well, a survey of OPate pharmacists highlighted in the sources found most worked at academic centers, used collaborative practice agreements, working closely with docs under protocols. And interestingly, it suggested a possible staffing ratio. Maybe one OP pharmacist for every 45 to 70 OP patients.
So defining a real growing specialized need.
Exactly. They're not just refining care for the sickest in patients. They're helping manage complex 4V treatments for patients at home or in clinics, too.
Their reach is definitely expanding. Let's talk public health more broadly. Where do ID pharmacists fit into things like vaccination, testing?
Their contributions here are getting much more recognition, and they're crucial. We see growing involvement in vaccination efforts and also in innovative point-of-care testing, POCT.
And there's solid evidence for their impact on vaccine uptake, isn't there?
Very solid. A big systematic review and meta-analysis, published 2025, looked at data up to late 2024. It found pharmacist involvement, just in general, significantly boosted vaccination uptake.
How much?
Across 22 studies, the pooled risk ratio was 1.58, meaning people were about 58% more likely to get vaccinated if a pharmacist was involved somehow.
And did it matter how they were involved, like just talking versus giving the shot?
Yes. The review noted the impact was even greater when pharmacists were actually acting as immunizers giving the shots. The risk ratio there was 1.76. Still strong for advocacy and education, 1.59, but highest when they administered the vaccine.
That data really supports expanding pharmacists' ability to actually give vaccines, doesn't it?
It absolutely does. These findings make a compelling case for broadening their roles globally. Huge potential to improve coverage, help overcome barriers, especially where access to traditional providers is tough.
And what about bringing testing closer to the patient, that POCT idea?
Point-of-care testing programs in community pharmacies, that's evolving. The ACCP IDSAP 2025 program has a module on community pharmacy POCT and treat programs, especially for respiratory infections.
So what does that involve?
Training pharmacists to use specific CLIA wave tests, simple tests with low error risk, and then apply clinical guidelines to potentially start treatment right there in the pharmacy.
So bringing diagnostics and maybe initial treatment right into the local pharmacy.
Exactly. It's a big step towards decentralizing ID care, making it more accessible, more timely. It could definitely take pressure off clinics and hospitals.
But it needs support, right?
Oh, absolutely. Needs strong regulatory frameworks, clear guidelines, proper training, and crucially sustainable ways for pharmacies to get paid for doing it.
Okay, clear their impact is growing in many areas. How is the value of all this being formally measured? Are we seeing hard outcomes?
Yes, the sources show a strong focus on quantifying that value, looking at measurable outcomes, both patient impact and effects on healthcare system resources.
We mentioned length of stay reduction earlier. Can you recap that as a key outcome?
Yes, it's a consistent finding. Pharmacist-led AMS and other interventions are linked to shorter hospital stays. Documented decreases range from 1 to 6 days in different studies.
And that tele-ASP study
Showed a clear 1.1-day mean reduction, very specific.
and the economic side. The cost savings must be significant.
The tele-ASP study, again, provides a great example. It documented a really substantial 74.1% increase in cost savings and cost avoidance after it was implemented.
From what to what?
It climbed from about $5.9 million before the program to over $10.3 million annually afterwards.
Wow. How do they actually generate savings like that? Is it just using cheaper drugs?
Not necessarily cheaper, but smarter use. Optimizing therapy, right drug, right dose, right duration. Avoiding unnecessarily broad antibiotics, preventing adverse drug events, which cost a lot and prolong stays. And of course, the savings from that shorter length of stay itself add up.
Makes sense. And what about that high acceptance rate for their recommendations we talked about?
Right. Those consistently high rates, 96.8% in the tele-ASP, nearly 90% in those curbside consults, that's a strong signal. It shows how much physicians and other providers really trust and value the ID pharmacist's expertise.
But does that high acceptance rate also maybe hint they're still underutilized? If their quick advice changes management almost 90% of the time, maybe formal consults should be the norm.
That's a really insightful point.
Yeah.
The success of structured programs like tele-ASP and the defined need for OPAT pharmacists, they really do argue for formalizing and expanding these roles more broadly, making sure their expertise is systematically integrated, not just sought out ad hoc.
Yeah.
The sources are clear. The escalating complexity of ID pharmacotherapy is the main driver here, pushing demand for these specialized roles way beyond just core AMS activities.
Okay, let's shift to the front lines of the resistance battle specifically. New antimicrobials. What's happening in 2024, 2025, and what's the pharmacist's role with these new tools?
Well, there is an active development pipeline, which is good news, especially for tackling tough MDR gram-negatives. But these new agents, they require incredibly careful handling. ID pharmacists are absolutely indispensable. Understanding them, integrating them, stewarding them right from day one.
Are there specific new drugs from this period highlighted in the sources?
Yes, several key beta-lactamate-lactamase inhibitor combinations.
Yeah.
BLBLIs. These pair an antibiotic with something that blocks resistance enzymes.
Okay, like what?
One is cefepimine metazobactam. It targets ESBL-producing Pseudomonas and Enterobacterales. It's approved for complicated UTIs in the US and EU, and importantly also for hospital-acquired and ventilator pneumonia in the EU.
So a potential alternative to carbapenem sometimes.
Exactly. Seen as potentially meropenem-sparing in certain cases, which is great for stewardship. And like many of these, it needs dose adjustment for kidney function.
Okay, good for ESBLs. What about those really difficult CREs, carbapenem-resistant Enterobacterales?
For CRE, especially those producing MBLs, metallobeta-lactamases, which are really tricky. Aztreonam-avibactam is crucial.
Why that combo?
Aztreonam is unique. It's not broken down by MBLs. Adding avibactam helps cover other resistance types, too. It's approved in the EU for complex infections and fills a critical gap, especially for MBL producers.
Does it cover everything?
No, it often needs other drugs added for gram-positives or anaerobes. And yes, renal dose adjustment needed, too.
Got it. So a key weapon against those specific really scary bugs. What about Acinetobacter baumannii, another major global headache?
For the Acinetobacter baumannii complex, including the notorious CRAB, carbapenem-resistant A. baumannii, sulbactam durlobactam is unique. Sulbactam actually has activity against Acinetobacter itself, and durlobactam protects it from resistance enzymes. It's approved in the U.S. for hospital and ventilator pneumonia caused by susceptible A. baumannii.
Anything else notable about it?
Yeah, the sources highlight it seems to have a better kidney toxicity profile compared to colistin, which is often a last resort for CE, but tough on the kidneys. So that could be a big clinical advantage, and yes, needs renal dose adjustment.
That could make a difference. Are there any entirely new classes of antibiotics emerging?
Yes, capotidecin is a big one. FDA approved March 2025 for uncomplicated UTIs. It's first in class, a triazosinephyline antibiotic. Totally new mechanism targeting DNA replication differently.
So it bypasses common resistance.
Exactly. Bypasses things like fluoroquinolone resistance.
Yeah.
Shown efficacy against common UTI bugs, including resistant ones.
A brand new mechanism sounds exciting, but also raises concerns about preserving it, right? We don't want resistance to develop quickly.
Absolutely. Crucial stewardship for capotidecin is heavily emphasized. The strong recommendation is reserve it. Use it for uncomplicated UTIs caused by documented MDR pathogens, not just routine empiric use for susceptible bugs, to minimize resistance selection pressure. There's also a specific concern noted by the WHO widespread use for common UTIs could potentially select for resistance in Neisseria gonorrhoeae, which we definitely don't want.
So the pharmacist's role here isn't just knowing about the new drug, but actively guiding how it's used, basically protecting its future.
Without question, their role is paramount. Integrating these novel therapies responsibly, ensuring judicious use based on resistance data and patient need, maximizing benefit while minimizing that critical resistance pressure right from the start.
Speaking of resistance, managing these MDR organisms is incredibly complex. What are the strategies being recommended in the latest guidance?
Yeah, managing MDROs is definitely not simple bug-drug matching anymore. It needs sophisticated, often individualized approaches. A key resource highlighted is the IDSA 2024 guidance on antimicrobial-resistant gram-negative infections.
What does that guidance really dig into?
It provides detailed recommendations for the toughest threats, ESBL-producing Enterobacterales, CRE, and importantly for CRE, the recommendations are broken down not just by infection type, but by the specific type of carbapenemase enzyme the bacteria makes, like KPC, NDM, or OXA48. It also covers difficult-to-treat resistant Pseudomonas.
Why is knowing the specific enzyme type so critical? Isn't CRE just CRE?
Not anymore, really. Different enzymes break down antibiotics differently. A drug that works against a KPC producer might be useless against an MBL producer. The guidance stresses getting susceptibility testing, AST, results for newer agents. and it generally advises against routine combination therapy if a single active drug exists.
That level of detail demands a really deep understanding from the pharmacist, doesn't it?
It absolutely does. Educational resources like ACCP's IDSAP 2025 program are designed for this depth. They cover managing specific MBROs like Acinetobacter, including global trends, high cerebrates in some areas, Pseudomonas, Enterobacterales, diving into resistance mechanisms, risk factors, newer options like how to use sulbactam durlobactam for street pneumonia.
It sounds like it requires moving way beyond just knowing which drug kills which bug. You need to understand the diagnostics, the specific resistance mechanisms, and then integrate all that with the actual patient in front of you.
Precisely. Far beyond simple matching. The need for this level of sophistication is why advanced specialization in ID pharmacy is becoming even more critical. It's essential for getting optimal outcomes with these challenging infections.
Okay, so understanding the bug and the drug is vital. What about making sure the drug actually gets to the bug effectively, especially in really complex patients?
Right, that leads us to therapeutic drug monitoring, or TDM, especially for antibiotics like the alactams we've been discussing. The sources highlight TDM as a vital strategy to optimize efficacy, minimize toxicity, particularly in certain patient groups.
Why is TDM so important for lactams, especially in, say, critically ill patients?
Well, the ACCP IDSAP 2025 curriculum has a chapter explaining this. In critical illness, for instance, the body undergoes huge physiological changes. Fluid shifts, kidney function changes, protein binding alters.
Right.
All this can dramatically change how drugs are distributed and eliminated, leading to really unpredictable drug levels. TDM means actually measuring the drug levels in the patient's blood.
To make sure they're in the right range.
Exactly. High enough to kill the bacteria effectively, but not so high they cause toxicity. The goal is hitting specific pharmacokinetic pharmacodynamic targets, PKPD targets, like keeping the drug concentration above the bug's MIC, its minimum inhibitory concentration.
Is this standard practice everywhere now for gut lactams?
Not quite standard everywhere for all critically ill patients yet. While the value is increasingly recognized, a 2022 review mentioned in the sources noted it wasn't quite standard of care across the board. Still need more definitive outcome data, clearer identification of who benefits most, so it's evolving, but definitely gaining traction.
Seems like it's approaching a tipping point, though.
It feels like it. Its inclusion in major educational programs like IDSP, advocacy from groups like SIDP, the Society of Infectious Diseases, pharmacists, it all suggests TDM is moving towards being more routine. This means pharmacists need advanced skills in PKPD, interpreting complex data, maybe using modeling software.
Okay. Shifting gears again, let's talk preparedness for emerging infectious diseases, EPADs. These seem to keep popping up, unfortunately. What's the pharmacist's role in getting ready and responding?
Pharmacists are increasingly seen as really integral members of public health preparedness and response teams for EDAs. Their roles cover surveillance, education for the public and other healthcare pros, and direct patient management during outbreaks.
But there are still challenges.
Oh, yeah. The sources highlight the ongoing need for vigilance and acknowledge persistent challenges in global surveillance systems, integrating data, coordinating responses, efficient reporting. It's complex.
Can you give some specific EID examples from the sources and the pharmacist's involvement?
Sure. For HPII H5N1 bird flu, ASHP has resources for pharmacists on patient education, managing antivirals like oseltamivir. The CDC is stressing ongoing surveillance, noting those 71 U.S. human cases from 2022 to mid-April 2025, mostly linked to exposure to infected dairy cows or poultry without proper protection.
What about mosquito-borne viruses? Dengue, chikungunya, Zika?
For these arboviruses, like chikungunya, where there's no specific antiviral, pharmacists guide symptomatic care, recommending appropriate pain relief, like acetaminophen, ensuring good hydration. It's actually notable that a pharmacist is even part of the WHO guideline development group working on arbovirus management.
That's significant involvement. And Mpox?
SIDP held a specific webinar in late 2024 for pharmacists, giving critical updates on the 2-dose Mpox vaccine, covered efficacy, identifying at-risk groups, details on pharmacist-driven vaccination programs, and even administration techniques, subcutaneous or intradermal injections, shows pharmacists are being trained to lead vaccination efforts for specific ESDs.
It really sounds like their role in EAs is evolving rapidly beyond just, dispensing drugs during a crisis.
Absolutely. It's moving towards more active clinical management, diagnostics, public health intervention, requires them to stay incredibly current on a whole range of potential threats.
Now, we really need to dedicate some time to a particularly urgent threat highlighted throughout these sources, Candida auris.
Yes, Candida auris. It's described not just as a concern, but as a significant, rapidly emerging, and frankly escalating multi-drug resistant fungal threat in healthcare settings worldwide.
What makes it so uniquely challenging? Why is it causing so much alarm?
It's tough for several key reasons. One, its high transmissibility. It spreads easily between patients and via contaminated surfaces. Two, its remarkable ability to persist in the environment for long periods makes outbreaks incredibly hard to stop. And three, its inherent tendency to develop antifungal resistance.
What does the spread look like? Is it really increasing that fast?
The epidemiology is genuinely alarming. U.S. cases surged nearly five-fold between 2019 and 2022. England reported its highest annual number in 2024. It's often resistant to common antifungals like fluconazole, and worryingly, it shows variable resistance to echinocandins and polyenes, often our last resort drugs.
And pan resistance.
The emergence of isolates that are resistant to all three major antifungal classes, is an incredibly serious development. The WHO designated C. auris a critical priority pathogen, same category as the most dangerous resistant bacteria.
So prevention and control must be absolutely paramount then.
Absolutely crucial. Early ID through targeted screening of high-risk patients on admission is vital. A December 2024 bulletin from Washington State DOH urged facilities to screen patients meeting specific risk criteria.
And infection control measures.
CDC guidance is very clear. Single rooms, dedicated equipment, strict contact precautions, gowns, gloves, meticulous environmental cleaning with specific EPA-registered disinfectants proven effective against C. auris. Rigorous hand hygiene, alcohol rubs preferred. And clear communication about a patient's status upon transfer. All critical.
And if someone does get infected, treatment.
Echinocandins are generally the recommended first-line empiric therapy while you wait for specific susceptibility test results. Liposomal amphotericin B is an alternative, especially if resistance is suspected or the patient isn't responding.
How long do you treat for?
For uncomplicated invasive infections, usually at least 2 weeks after the first negative blood culture and symptom resolution. Longer for complicated infections. And source control is absolutely critical. Remove infected lines, drain abscesses.
Are there any potential newer options being discussed for resistant CRs? It sounds like we need them.
Yes, novel antifungals in development, like ibrexafungerp and fosmanogepix, have shown promising activity against CRs in the lab, including against some resistant strains. They're being explored as potential future options for these difficult cases.
And the pharmacist's role in managing CRs, is there specific antifungal stewardship guidance just for it?
Well, dedicated CR's antifungal stewardship guidelines might not always be separate documents, but the pharmacist's role is implicitly crucial. It's deeply embedded in overall ID and stewardship.
How so?
Their expertise is essential, guiding therapy based on those critical susceptibility results. Optimizing dosing, maybe using higher mycofungin doses for isolates with higher MICs, evaluating if combination therapy might be needed, monitoring for resistance emergence during treatment, understanding where novel agents might fit. It demands an urgent, sophisticated antifungal stewardship approach, truly mirroring the intensity we put into fighting resistant bacteria.
It really sounds like managing Candida auris requires the same level of intense focus, data analysis, and expert strategy as fighting the toughest bacterial superbugs.
It absolutely does, and the sources even link this back to the One Health concept again, suggesting that widespread agricultural use of certain azole fungicides might be contributing to environmental antifungal resistance, which could impact human pathogens like C. auris.
Wow. Okay, let's broaden out again. Look at the professional landscape supporting ID pharmacists through all this complexity. What are organizations like IDSA, ACCP, ASHP doing?
These groups play a vital role. They're constantly developing and updating clinical practice guidelines, providing comprehensive educational programs, supporting board certification, and doing crucial policy and advocacy work.
Can you give some examples of recent IDSA guidelines? They seem very active.
Incredibly prolific. In 2024-2025 alone, they've released or updated guidelines on things like histoplasmosis, TB, COVID-19 treatment, diagnostics, primary care HIV, intra-abdominal infections, lab ID guidance, and of course that detailed 2024 AMR gram-negative guidance we discussed.
And more coming.
Definitely. A significant pipeline expected in 2025 covering surgical prophylaxis, community-acquired pneumonia, hospital-acquired ventilator-associated pneumonia. The list goes on.
That volume alone shows how fast the field moves.
What about educational programs like IDSAP?
ACCP's IDSAP 2025 is a prime example. Covers a huge range. Managing specific MDROs, hepatitis C and B, those community pharmacy POCT programs, herpes viruses in immunocompromised patients, using NHSN AUR data for stewardship, regulatory updates for ASPs, and that important beta-lactam TDM section.
And ASH.
Their IDSAP Book 2 from late 2024 specifically focuses on infections in special populations, pediatrics, OPP, really tailored content.
And are these programs linked to pharmacists demonstrating their advanced expertise, like certification?
Yes, they're essential for pharmacists preparing for and maintaining the board certification in infectious diseases pharmacy, the BCIDP. That certification is a key way to validate their advanced knowledge and skills.
What about policy and advocacy? Are these organizations trying to shape the future of the profession itself? Absolutely.
Right.
And it's becoming increasingly vital work. IDSA, for instance, has a strategic vision for the entire ID workforce that explicitly includes clinical pharmacists as essential members of team-based care.
So promoting team care.
Yes, and advocating for increased federal funding for ID training, early career development, initiatives like the Biopreparedness Workforce Pilot Program, pushing for resources.
And funding for the actual jobs.
Exactly. Advocating for diverse, sustainable funding models to support these expanding pharmacist roles beyond just traditional AMS. Things like direct billing for clinical services, better integration into value-based care, dedicated institutional funding.
And what about expanding what pharmacists are actually allowed to do legally, scope of practice?
Definitely. Policy advocacy is needed to modernize state laws, allowing pharmacists to practice at the top of their training in areas like providing HIV prevention meds, PEP, or conducting certain tests, aligning regulations with their capabilities.
It seems like the sheer volume and specificity of all these guidelines and educational programs, it almost points towards increasing subspecialization even within ID pharmacy itself, like niches.
That's a really insightful point, and the sources certainly imply that. The level of detailed knowledge needed for specific pathogens, novel drugs, complex patient groups. It means ID pharmacists may increasingly focus on particular areas, requiring even deeper specialization.
And all this policy and advocacy work is essential to make sure the incredible value they're demonstrating actually translates into stable jobs and a broader impact.
Exactly. It's crucial to translate that documented clinical and economic value into sustainable workforce models and an expanded scope of practice, letting them fully utilize their hard-earned expertise.
Okay, we have covered a tremendous amount of ground in this deep dive. Let's try to synthesize some of the key trends shaping the future of ID pharmacy based on everything we've discussed from these sources.
Right, pulling it all together. We see several major trajectories. Greater integration of AI definitely happening, but crucially, with pharmacist oversight and validation.
Not replacement.
Not replacement. We'll also see continued expansion of pharmacist-led services out into outpatient and community settings, POCT, chronic ID management, OPET.
And the resistance fight continues.
Oh, yeah. Continued development and, just as importantly, essential stewardship of novel antimicrobials. Hand in hand with that is enhanced antifungal stewardship, driven by urgent threats like Candida auris, and ongoing efforts to optimize vaccine strategies, address hesitancy, improve access globally.
Any broader system trends?
Strengthening global collaboration and preparedness networks is key, as is developing new funding and practice models to actually support these evolving roles.
You also mentioned precision stewardship earlier. Can you elaborate on that as a future direction? What does that look like?
Precision stewardship. It's really about leveraging advanced tools, genomics, AI, rapid sophisticated diagnostics, to tailor antimicrobial therapy much more precisely to the individual patient, their specific bug, moving beyond broad empiric guesses to highly individualized, data-driven treatment.
And pharmacists are key there.
Central to interpreting and implementing these complex precision strategies. They're the ones who can connect the dots.
That level of personalization sounds incredible. What about addressing health disparities? Is that becoming part of the ID pharmacist's role?
It's a growing focus, cultivating culturally competent care, actively advocating for equitable access to prevention, diagnosis, treatment. These are becoming more important aspects, especially as pharmacists move more into community settings. They'll be right there, encountering and needing to address these inequities.
And finally, that One Health concept, connecting human, animal, environmental health. How does that fit in?
Yes. The sources suggest this is becoming a more deeply integrated understanding. Examples like the potential link between agricultural fungicides and C. auris resistance, or the dynamics of zoonotic diseases like bird flu. They highlight that the drivers of AMR and EIs aren't just in human healthcare.
So pharmacists need a broader view.
They need to understand these broader ecological connections, potentially collaborate more with vets, environmental health officials, policymakers. Thinking bigger picture.
So the scope of an ID pharmacist's influence is truly expanding beyond the hospital into the community, even into understanding these wider environmental factors.
Exactly. And all the quantitative data we've talked about, AMS evolution, vaccination impact, the cautious role of AI, it just reinforces the tangible value, the multifaceted contributions ID pharmacists are already making to global health.
So what are the really big takeaways from this deep dive into the very dynamic world of infectious diseases pharmacy?
Well, we've seen a field rapidly expanding its expertise, its reach, armed with increasingly sophisticated tools, battling complex and urgent threats like Candida auris, and consistently proving its value. Measurable impacts on patient outcomes, healthcare costs.
We've also glimpsed a future pushing towards that personalized, data-driven precision stewardship, deeper engagement in public health, and even understanding health through that interconnected One Health lens.
With all this incredible advancement, the increasing sophistication required, and, let's face it, the continuous emergence of new challenges.
Here's something to really consider. A provocative thought, maybe. As managing infectious diseases becomes more complex, requiring highly specialized knowledge and tailored treatments often delivered by specialists or through advanced systems, how do we make sure that fundamental access to essential infectious disease prevention, diagnosis, and care remains equitable? How do we ensure it's available for everyone, everywhere, regardless of where they live or their access to these advanced resources?